Welcome back to This Week in Pulmonary and Critical Care Medicine. I'm your host, Aladdin Sagar, and this week we're unpacking a couple of studies and one major regulatory approval that could shift parts of our clinical practice. We'll start with a pragmatic randomized bronchoscopy trial, move on to an important antifibrotic therapy update, look at the recent FDA approval of Nerandomilast, and end with a major review article on lung cancer in non-smokers, a population that's often under-recognized in screening discussions. As always, this episode is for educational purposes only. It's meant to keep you current and sharp, not to offer patient-specific recommendations. Let's dive in. First up, a well-designed, pragmatic randomized trial published in Chest tackling a common procedural dilemma. Does using an ultrathin bronchoscope with radial EBUS or adding rapid on-site cytology evaluation actually improve diagnostic yield for peripheral pulmonary lesions? This was a multi-center factorial RCT with 181 patients across several Canadian centers. All lesions were peripheral, mostly under 5 centimeters, and importantly, these were N0 patients, meaning no radiographic mediastinal lymphadenopathy. The malignancy prevalence was high, 84%. The diagnostic yield using a standard thin bronchoscope was 65.6%. With ultrathin, it was 58.2%. That's a difference of minus 7.3 percentage points. However, it was not statistically significant. Sensitivity for malignancy was 84.3% versus 74.3%. Again, no statistical significance. With ROSE, the diagnostic yield was 60.4% versus 63.5% without it, a difference of minus 3.1 percentage points, also non-significant with a p of 0.76. Sensitivity hovered around 80% in both arms. Procedure times were slightly longer with ROSE, but not dramatically so. Adverse events were minimal, essentially confirming that both approaches are safe. From a bedside perspective, this study is important because ultrathin bronchoscopes are expensive acquisitions, and ROSE requires real-time pathology support. This trial suggests that, at least for straightforward peripheral lesions in N0 patients, neither strategy provides a clear diagnostic advantage over standard thin bronchoscopy with rebus. That doesn't mean these tools have no value. There may be specific niche scenarios, for example, smaller segmental lesions or centers with limited access to percutaneous biopsy, where ultrathin scopes could help. But routine use purely to increase yield, this trial strongly argues against it. In short, good old thin bronchoscopy remains a reasonable first diagnostic step in many cases. Let's move to IPF, where therapeutic progress has been painfully slow over the past decade. The FibroNear IPF trial was a large, Phase 3 study evaluating Nerandomilast, a phosphodiesterase 4B inhibitor, as an add-on or standalone antifibrotic therapy. This subgroup analysis focused on 196 U.S. patients out of the global cohort of 1,177. The results were shared as an abstract in the Chest conference this week. Their mean age was 73, 82% were men, mean FVC was 76.5% predicted, and DLCO was 50.9% predicted. More than 80% were already on background therapy, nintedanib in 53% and pirfenidone in 30%. After 52 weeks, the FVC decline was 257.9 milliliters in the placebo group, 152.7 milliliters with Nerandomilast 9 milligrams, and 126.2 milliliters with Nerandomilast 18 milligrams. That's an absolute difference of 105 milliliters and 132 milliliters in favor of Nerandomilast. The 95% confidence intervals for both doses confirming statistical significance. For the composite endpoint of acute exacerbation, hospitalization, or death, for placebo it was 30.0%, 21.4% for the 9 mg dose with a hazard ratio of 0.86, and 19.6% for the 18 mg with a hazard ratio of 0.74. That's an absolute risk reduction of around 10 percentage points with the higher dose when compared to placebo. Adverse events were primarily gastrointestinal. Diarrhea occurred in 14.3% of placebo, 34.3% of the 9 mg group, and 42.9% of the 18 mg group. But discontinuation rates were surprisingly lower with nerandomilast, 10 to 13%, than with placebo, 15.7%. What's striking here is that this benefit occurred on top of background antifibrotics. Historically, combination therapy hasn't produced consistent additive effects. A preserved FVC difference of over 100 milliliters may not sound glamorous, but in IPF, that's clinically meaningful, especially if sustained over several years. This positions nerandomilast as a potential third pillar in IPF management, alongside nintedanib and pirfenidone. And that leads us directly into the regulatory update. On October 18, 2025, the FDA officially approved nerandomilast under the brand name JASCAYD for the treatment of idiopathic pulmonary fibrosis. The recommended starting dose is 18 milligrams twice daily, with an option to step down to 9 milligrams if needed. Tablets can be dispersed in water for patients with swallowing difficulty. Dose adjustments are required if the patient is on strong CYP3A inhibitors, and the drug should be avoided with inducers. This marks the first FDA approval of a new IPF therapy in years. The approval is based on the Pulmonary IPF trial, which demonstrated a clinically and statistically significant reduction in FVC decline. The adverse event profile was dominated by GI issues, diarrhea, weight loss, decreased appetite, but most were mild to moderate. Other reported effects included fatigue, headache, and upper respiratory infections. Notably, discontinuation due to adverse events was lower than what we've seen historically with other antifibrotics. The real-world impact here is going to hinge on how well we can layer this therapy with existing treatments. Payers, cost, and patient tolerance will be critical. But from a purely clinical standpoint, the approval expands the therapeutic toolbox for a disease where survival remains just 3 to 5 years for many patients. It's a meaningful step forward. Let's shift gears to a very different topic: lung cancer in people who have never smoked. This review, published in JAMA, highlights a major and often overlooked public health challenge. Globally, 15 to 20% of lung cancers occur in non-smokers. Those numbers are not trivial. They're on par with some cancers for which we screen aggressively. Most tumors are adenocarcinomas, 60 to 80%. EGFR mutations are found in 43% of cases, compared with 11% in smokers. ALK rearrangements in 12% versus 2% in smokers. These tumors also have lower mutation burdens, often under 3 mutations per megabase. The median age of diagnosis is around 67, just slightly younger than in smokers. And importantly, the majority are diagnosed at advanced stage because they are not screened. The U.S. Preventive Services Task Force currently does not recommend low-dose CT for non-smokers, but this is not just about epidemiology. It's about biologic differences and treatment opportunities. Patients with EGFR or ALK alterations and advanced disease can have median survivals of 3 to 5 years on targeted therapy. Those without actionable mutations have survival closer to 1 to 2 years. This highlights a growing gap between where screening guidelines are and where the disease is moving. Air pollution, radon, asbestos exposure, and family history are emerging risk factors that may inform future risk-based screening strategies. From a practical perspective, it means we should maintain a low threshold for diagnostic imaging in non-smokers with symptoms and ensure comprehensive molecular testing for anyone diagnosed. Treating this as a distinct clinical entity, not just a subset of smokers' lung cancer, is key. To wrap up, the bronchoscopy trial shows that more technology doesn't automatically mean better results. The nerandomilast data signals a meaningful additive option for slowing IPF progression, and the FDA has acted quickly to make it available. And finally, lung cancer in non-smokers continues to rise, biologically distinct, underscreened, but often highly targetable. This is the kind of evidence that shapes how we think and practice, not just tomorrow, but years down the line. If this episode was useful, share it with a colleague, subscribe, or leave a review. I'll be back next week with more evidence distilled for busy clinicians. Until next time, keep questioning, keep learning, and keep caring for your patients.